Okay, so my name is Brona Maloney. I'm an instructor in medicine at Harvard Medical School and an associate physician at Brigham and Women's Nephrology Division, where I attend. And today I'm delighted to give a talk on anemia management update and best practices. So just a little bit of background, a little bit of my background training there. I have an interest in advanced clinical trial design, and my research interests are autonomic dysfunction, inflammation, and adverse cardio-kidney metabolic outcomes across the spectrum of kidney disease. So I have no disclosures for the presentation today that are relevant. And the objectives of this talk are to review the current understanding of anemia pathophysiology in CKD and dialysis patients, look at some of the updated guidelines, in particular the KDIGO 2026 guidelines and the evidence around them, and compare some of the therapeutic options, including the novel agents, so the HIF-PHIs or the prolyl hydroxylase inhibitors, and how they feature in the 2026 guidelines. And then there'd be some case questions along the way and some clinical vignettes. So briefly, I just want to first talk about the pathophysiology of anemia in CKD and dialysis patients. So I think you can break this down into kind of 5 main concepts. So the first is that of iron-restricted erythropoiesis. And so iron availability is controlled by the liver hormone hepcidin, which regulates dietary iron absorption and also regulates macrophage iron recycling from senescent red blood cells. And there are several feedback loops that control hepcidin levels, including iron and EPO. So in patients with CKD and who are on dialysis, we know that hepcidin levels are increased, and this is due to a combination of reduced clearance and also the pro-inflammatory state that we now increasingly recognize as CKD is. And so you get higher hepcidin levels, which ultimately leads to this thing called iron-restricted erythropoiesis. And I'll do a little bit more on that in the next few slides. We also know that patients with CKD have inhibition of EPO production, the hormone crucial for erythropoiesis. And then, of course, there's this concept now of uremic inhibitors of erythropoiesis. So, for example, some substances such as indoxyl sulfate are gaining increased recognition in this regard. Patients with CKD, we know, have shortened red blood cell lifespan due to a combination of factors such as oxidative stress and inflammation, all of which impede erythropoiesis. And finally, we are well familiar with the fact that patients with CKD and dialysis often have increased episodes of blood loss, whether it's from the dialysis procedure itself or frequent hospitalizations necessitating frequent blood draws. So I think, there's lots of causes for anemia and CKD, certainly, but, central to this is this concept of erythropoiesis, which is regulated by EPO, the hormone, and is specifically done through the hypoxia-inducible factor system. So very briefly, what I want to show here is that HIF, or the hypoxia-inducible factor, when triggered, stimulates the kidneys to produce the hormone EPO. And this process is actually very tightly regulated. You can see here with EPO production about 2 units per kg per day. Endogenous EPO half-life is actually quite short, about 5 to 8 hours, and it acts on erythroid progenitors in the bone marrow to stimulate RBC production at about a rate of 2 by 10 to the 11 per day. But there's also this concept of ongoing RBC loss with a loss of about 0.8 to 1% per day, and so there's this constant need to maintain continuous erythropoiesis. What's important in a clinical setting is that we use ESA treatments such as EPO alpha, beta, darbepoetin alpha, etc., shown here in the yellow box, to mimic endogenous EPO. But these often have much longer half-lives, so anywhere between 8 and 120 hours, depending on the compound used. And so they support RBC production, for example, in patients with CKD. So if we go one step forward, I think it's important then to understand the relationship between iron metabolism, hypoxia-inducible factor pathways, and actually erythropoiesis itself. So you can see here on the left of this diagram that in response, to low iron availability, reduced oxygen tension, or even with the agents, the HIF prolyl hydroxylase inhibitors, that the HIF alpha unit is stabilized, and then you get an increase in EPO synthesis. This stimulates the erythroid progenitors in the bone marrow and boosts overall erythrocyte production. So as RBC production rises, erythroferrin is released, which decreases hepcidin expression and increases iron mobilization. So HIF activation also regulates iron metabolism by increasing iron absorption from the gut and exporting it to the circulation via ferroportin, which is kind of the iron exporter. And so this all helps meet the iron demand that's required for hemoglobin synthesis. And with increased iron use, over time, your ferritin and your T-sats will drop, but over time, overall iron availability improves. And so this then ultimately leads to downregulation of HIF activity, in particular the HIF2 alpha unit, and then completes the feedback loop. So I think whilst the pathophysiology, may be reasonably straightforward, I think you can't say the same about the evolution of therapeutics targeting this pathway. And so this timeline is a brief and broad overview of some of the wins and the challenges in that regard. So ranging from the early discovery and development of EPO in 1905 and 1977 then, and then the FDA approval of ESA use in CKD in 1989. Then, of course, there was the emergence of the cardiovascular safety concerns, particularly with the CHOIR and the TREAT study, which I'll reference a little bit later. And then, of course, the guidelines had to reflect some of these emerging concerns in terms of their threshold targets. And then more recently, since 2020, we have the emergence of the HIF-PHIs, which hasn't exactly been straightforward either, with subsequent withdrawals from the market. And I'll allude to that a little bit later. So despite this complex landscape, thankfully, we've guidelines to guide clinicians in the management of anemia. And more recently, we have the KDIGO 2026 guidelines, which are what I'll reference for this talk, and use it as an opportunity maybe to compare and contrast against some of the 2012 guidelines on what's new. So firstly, in terms of testing for anemia, it's advised that we test at least annually in patients with CKD3, at least twice per year in patients with CKD4, and then every 3 months in patients with CKD5 or who are on dialysis. The diagnosis is made with a hemoglobin of less than 13 in males, less than 12 in females. And what's really interesting in the 2026 guidelines is, there is such an emphasis on ensuring that there's a broad and comprehensive workup in identifying any other correctable underlying causes for anemia. And so there is a listed workup as shown here in the 2026 guidelines, which essentially involves excluding everything from, an underlying TMA, nutritional deficiencies, whether there's an underlying plasma cell dyscrasia or uncontrolled or suboptimally controlled parathyroidism, or even occult GI bleeding. So I think once anemia is recognized and you've done your broad workup to make sure that there's no other correctable causes, what's important is to identify whether in CKD the patient is iron deficient. In CKD non-dialysis or CKD5 for patients on peritoneal dialysis, the indication for iron is TSATs less than 40% and a ferritin less than 100, or TSATs less than 25% and a ferritin greater than 100 or less than 300. And this is important to note in the 2026 guidelines, as it differs from the prior guidelines of 2012, where the ferritin threshold has been lowered from 500 region to down to 100. The recommendation is that oral iron be used, a 1 to 3 month trial of oral iron or intravenous iron. So what's also important to emphasize from the 2026 guidelines is this idea of individualization according to patient preferences. And we know oftentimes in clinical practice that many patients won't tolerate oral iron due to constipation. So there is emphasis certainly about individualization and choosing the appropriate preparation according to what best suits your patient. Monitoring, so further doses should be guided by hemoglobin response, TSAT, ferritin, ESA responsiveness, and then the recommendation is that we evaluate iron status every 3 months. Then for hemodialysis patients, similarly, the indication is that you initiate iron therapy when the TSATs are less than or equal to 30% and the ferritin is less than or equal to 500. That's actually similar to the 2012 guidelines. The preference in this instance is direct to IV iron in patients on hemodialysis. And actually in the 2026 guidelines, the emphasis is on very much a proactive higher dose IV iron, and that's extrapolated from the pivotal trial. Monitoring further doses again should be guided by hemoglobin response, TSATs, ferritin, ESA responsiveness, and then evaluate the iron status every 1 to 3 months. Okay, so what's also interesting in the 2026 guidelines is some interesting practice points. So for the first time, they actually give guidelines on when one should withhold iron. So a ferritin greater than 700 or TSATs greater than or equal to 40%. Again, this is extrapolated from pivotal trial. Some additional practice points. Again, as I mentioned before, switching from PO iron to IV iron if insufficient effect on optimal oral regimen after 1 to 3 months or of poor tolerability. So the idea is you don't really wait around. If the patient isn't responding after they've been on an optimal oral regimen, you should probably switch them over to intravenous iron. Again, consider temporarily suspending iron therapy during systemic infections. And also CKD and iron deficiency without anemia. So what do you do there if the patient doesn't actually have anemia but has abnormal metrics? So you would consider replacement if the treatment if the ferritin's less than 30 and the TSATs are less than 20%, which is interesting. So this slide again, I pointed out these differences as we've gone along there, but just this is a comparison between the 2012 and the 2026 guidelines. Just noting that new ferritin threshold in patients on PD and our patients who are not on dialysis, and also the upper safety stop, which is new in 2026, of withholding ferritin or withholding iron, if the ferritin is greater than 700 or the T-sets are greater than or equal to 40%. Okay, so I'm not going to go into oral iron preparations, but I do want to kind of spend some time in the IV iron preparations. So these are kind of some of the commonly used preparations that we often see, I think, in the dialysis units or the infusion suites. And what I want to kind of draw attention to here is that all the preparations are colloids that have an iron oxyhydroxide core, and that core varies between the preparations in size and density. This core then is surrounded by a carbohydrate shell, and that shell actually stabilizes the core. And by doing so slows the release of iron. And what's interesting is that carbohydrate shell differs by preparation, and that ultimately is what affects the stability, the dosing, and even the reaction risk between the different compounds. So with that said, I just want to go through a quick case. So this is a patient with iron deficiency anemia who receives IV iron therapy and subsequently develops severe hypophosphatemia with symptoms of muscle weakness and fatigue. So which of the following IV iron formulations is most likely to cause this patient's hypophosphatemia, and what is the underlying mechanism? So A, iron dextrin via inhibition of sodium phosphate co-transporters in the kidney. B, ferric carboxymaltose via increased levels of FGF23. C, iron sucrose through decreased PTH secretion. Or D, femoxytol via decreased intestinal phosphate absorption. So I'll just give you some time to think about that. And so the answer there is actually B. And so why is that? So this is just an interesting slide which shows the incidence mechanisms and consequences of IV iron-induced hypophosphatemia. So on the top left here of this, you can see that ferric carboxymaltose compared to other IV iron preparations is actually, in this series, the highest incidence and severity of hypophosphatemia. And so you can see in the orange that there were incidences of the phosphate dropping below 1 mg per deciliter. Then at the top right, you can see that based on the orange, how the serum phosphate levels drop sharply after FCM and actually can remain low for extended periods of time in severe cases. So you can see here that at 2 weeks, the phosphate was already below 1, and then this was prolonged up as far as, at least week 12 follow-up. I think the challenge with this is that it's very hard to discriminate between IV iron-induced hypophosphatemia and an iron deficiency on a clinical basis, and you can see in the Venn that a lot of the signs and symptoms overlap. And what is relevant to the answer to that question, which was ferric carboxymaltose and answer B, is that the treatment is actually challenging. And so why is this? Well, if you think about the underlying mechanism, FCM will cause an increase in FGF23. And so this reduces renal phosphate reabsorption from the proximal tubule. And so you get this renal phosphate wasting, or essentially renal leak. The other mechanism by which it works is that it'll suppress your 1-alpha hydroxylase, therefore leading to a reduction of 1,25-dihydroxyvitamin D. And so you get a reduction also in intestinal phosphate reabsorption. And so the reflexive thing for physicians to do, I think, will be to immediately, the minute when they see a low phosphate, is to replete it with IV or PO repletion. But the problem is, if you think of the mechanism is due to an increased level of FGF23. And unfortunately, by giving supplementation, you can paradoxically increase FGF23 levels and therefore worsen the actual underlying issue, which and potentiate, I suppose, this renal phosphate wasting. So really, primary prevention is the best approach, and perhaps avoidance of FCM in that instance. So now that we've covered iron therapy, I think let's turn to the role of erythropoiesis stimulating agents, or ESAs, in anemia management. And so the practice points from the 2026 guidelines suggest that we address all correctable causes of anemia prior to treatment initiation. And then in anemia and CKD, in whom correctable causes of anemia are addressed, ESA rather than HIF-PHIs or the prolyl hydroxylase inhibitors are first line. And this is explicitly said in the 2026 guidelines and not in the 2012. So for patients, CKD non-dialysis, kidney transplant, and pediatrics, the recommendation is we initiate ESA if the hemoglobin is less than or equal to 8.5 to 10 grams per deciliter. And the hemoglobin concentration at which we initiate should be individualized based on symptoms, weighing up benefits versus risks and kind of the clinical scenario. So, for example, if it's a patient who may be going forward for transplantation and you want to avoid sensitization, well, obviously your threshold that may influence the threshold at which you target or at which you initiate ESA. And the idea is you target the hemoglobin level to below 11.5, and you'll see based on some of the studies why so. In patients who are on hemodialysis or on peritoneal dialysis, the guidelines suggest we initiate ESA if the hemoglobin is less than or equal to 9 to 10 grams per deciliter, but you want to avoid the hemoglobin falling below 9. Again, individualization is reasonable and ESA may need to be started above 10 grams per deciliter. And you want to target the hemoglobin level to below 11.5. So that's reiterated there again. And so I think what's also interesting, there's just a few other interesting practice points that I want to draw your attention to. So one is this concept of you want to avoid adjusting the dose of ESA more frequently than once every 4 weeks. So that can be actually harder to do in practice, I think. The exception is if the hemoglobin increases by more than 1 gram per deciliter in the 2 to 4 weeks after ESA initiation. In that case, the suggestion is that you reduce the dose by 25 to 50%. The emphasis being on reducing the dose. So rather than holding the dose to avoid a rapid hemoglobin decline, unless the hemoglobin is greater than 11.5 grams per deciliter. And you'll see some of the evidence base behind that in a second. You want to also use the lowest dose possible that achieves and maintains treatment goals. And then finally, what's interesting in the 2026 guidelines is they specifically highlight what to do with ESA use during hospitalization. So it's reasonable to suspend ESA use during hospitalization for acute stroke, vascular access thrombosis, or thromboembolic events. And then finally, active cancer or a history of cancer necessitates shared decision-making. And again, in the 2026 guidelines, there's lots of emphasis on shared decision-making and personalizing according to patient preferences. So, when you look at the last 2 points there, you got to wonder what's the rationale for this caution. But I think if I briefly take you through some of the anemia trials, you'll understand some of the reasoning behind these points. So, in that regard, we had the normal hematocrit study. This patient population for this was patients with heart failure, ESKD on dialysis. Patients were randomized to a target hematocrit of 42% versus 30%, the higher hematocrit versus lower hematocrit. The primary outcome for this study was time to death or first MI. And this study was stopped early at the third interim analysis because there was a trend towards an increased risk of the primary outcome in the higher hematocrit target group. There was a subsequent follow-up post-hoc analysis which shows a higher rate of thrombosis in the higher hematocrit group, and an increase of events with higher EPO doses. And so the conclusion from the normal hematocrit study was that the use of EPO to target the higher hematocrit of 42% in any patient with clinically evident heart failure or ischemic heart disease on dialysis was not recommended. And then we had the CREATE trial. That was the normalization of hemoglobin level in patients with CKD and with anemia. These were patients with CKD, GFR between 15 and 35, and patients were randomized to a target hemoglobin of between 13 and 15 versus a target HB of between 10.5 and 11.5. And epoprotein was initiated randomization, or if the hemoglobin target fell below 10.5, and the primary endpoint was time to first cardiovascular event. What they found was there was a trend towards an increased risk of the primary outcome in the higher hemoglobin group, but it was not significant. And there was actually no difference in the combined incidence of adverse events between the two groups, but hypertensive episodes and headaches were actually more prevalent in the higher hemoglobin group as well. So ultimately, the conclusion from the CREATE trial was that there was no benefit in cardiovascular risk reduction with early anemia treatment. And so following on from CREATE came the CHOIR study, which was correction of hemoglobin and outcomes in renal insufficiency. This was an open label trial of 1,432 patients. These patients had also had CKD, and they were randomized to a target HB of 13.5 versus 11.3 with EPO alpha. And this study, the results were an increased risk of the primary outcome, which was a composite of death, MI, heart failure, hospitalization, and stroke. And so the conclusion ultimately from CHOIR was that a target hemoglobin of greater than 13 was associated with an increased risk of cardiovascular events. That was the kind of key point from that study. Following on from CHOIR came TREAT. And the important thing with TREAT to note is that this was, the first placebo-controlled trial. So TREAT had 4,038 patients. These patients had CKD with diabetes, GFR between 20 and 40. And patients were randomized to darbepoetin alpha versus placebo to achieve a hemoglobin of 13 with rescue darbo instigated when the hemoglobin was less than 9. The co-primary endpoint was a composite of death or cardiovascular events, or composite of death or ESKD. And so while this trial found no difference in the co-primary outcomes between treatment groups, there was a markedly higher risk of stroke in the treatment group and a higher rate of malignancy associated mortality. And so I think these graphs interestingly reflect actually how practice changed in terms of hemoglobin, what people were actually doing on the ground in terms of hemoglobin targets and ESA dosing following Choir and TREAT. So you can see the continuous grey line reflects the EPO alpha dosing. The yellow zigzag line at the bottom reflects hemoglobin in patients on EPO alpha. And you can see that there was a sharp decline from a mean HB of about 12 in 2007 to a mean hemoglobin of 10.5 by 2012, with a similar pattern of reduction in the mean EPO doses. And since then, if you actually look at practice patterns in the US, using the US RDS data, at least up to 2023, we've consistently maintained that practice with mean hemoglobin levels of about 10.5 in both HD and dialysis or PD patients using ESAs. So, building on from the TREAT trial and the concerning finding around ESA and malignancy, I think KDIGO 2026 take a cautious stance when it comes to ESA use in patients with CKD and cancer. So what they specify is that active cancer or history of cancer necessitate shared decision-making based on patient preferences, especially when cancer treatment is aimed at cure, with a target HB that minimizes transfusion risk. So big emphasis again on the shared decision-making concept. And if you look at how this aligns with the ASCO or the ASH 2019 guidelines, which is obviously not specifically for patients with cancer and CKD, but patients with cancer and how they recommend ESA use, they recommend it for chemo-related anemia when the hemoglobin is less than 10 for symptom control. So very much, symptom control, palliative approach, taking all those things into account, but to be maybe a little bit more cautious where there's curative intent. But again, shared decision-making, which is a theme in the KDIGO 2026 guidelines. Okay, so let's look at another case. So this is a case of a 59-year-old man with ESKD on thrice-weekly hemodialysis. This patient has persistent anemia despite high-dose ESA therapy, and that's the bottom line to take from the STEM. Current meds include EPO alpha, 15,000 units IV 3 times a week. He's on a total dose of 45,000 units a week. And he's also receiving IV iron sucrose monthly. So his recent labs reveal a hemoglobin of 8.8. So the point here being this gentleman isn't incrementing despite a stable dose for 2 months on high-dose ESA. Ferritin 950, TSAS 19%. He's obviously getting active IV iron sucrose. He's got CRP 24 mildly elevated, but nothing out of the ordinary of what one might expect in a dialysis patient, given their chronic inflammatory state. PTH of 1,400 is obviously elevated. There's no evidence of blood and stool, nothing to suggest he's got a TMA or any kind of underlying potential blood dyscrasia. And his dialysis is adequate with a KT overview of 1.5 at least. So what is the most appropriate next step in management? Increase ESA dose, stop iron and obtain a bone marrow biopsy, start cinecalcid or perform PTH imaging or parathyroid imaging, or transfuse 1 unit of packed red blood cells or begin oral corticosteroids. So I'll give you some time to think, but I think the most reasonable answer probably here is C. And so what is the point of this STEM? Well, what I want to highlight here is this concept of ESA hyporesponsiveness, and looking, to see, is there potentially correctable underlying cause for a patient not responding to high-dose ESA? And so, this shows here some easily correctable, potentially correctable, or impossible to correct scenarios. So things you might want to consider is their underlying nutritional deficiencies, even hypothyroidism, ACE/ARB use, and whether a patient is receiving adequate dialysis, with their underdialyzed. You might need to review their hyperparathyroidism regimen, or whether or not you need to even consider an underlying plasma cell dyscrasia and even bone marrow biopsy. So these are some of the things, that should prompt what should prompt you to do, some of the things that you should be prompted to do next when you identify this clinically in a patient. And this is then obviously some of just the workup that might be involved. So with that said, I want to just focus on some ESA monitoring, how it appears in the 2026 guidelines. So they do suggest that you monitor the hemoglobin every 2 to 4 weeks following ESA initiation or dose change. And that you monitor the hemoglobin at least once every 3 months then when the patient kind of is on a maintenance dose. There's also this concept of ESA hyperresponsiveness, which makes quite an appearance in the 2026 guidelines. So firstly, it's being able to recognize this. So initial ESA hyperresponsiveness is kind of defined as no increase in hemoglobin after 1 month of appropriate weight-based dosing. And then there's this acquired or subsequent ESA hyperresponsiveness. So if after stable ESA doses, there is a need for 2 increases or up to 50% more to maintain a stable hemoglobin. And so why is this important? Well, I've already outlined some of the, workup that's required when you do recognize this, but also it's important to know there's about 30% of patients in whom you'll find no cause for ESA hyperresponsiveness. But what we're increasingly recognizing is that it can be associated with adverse clinical outcomes. So this was actually a nice paper by Finney McCausland and Ajay Singh, where they looked at the association of different definitions of ESA hyperresponsiveness with major adverse cardiovascular events. And this was a secondary analysis of the ASCEND-D trial. And what they found was using 3 definitions that they were all associated with a higher risk of composite major adverse cardiovascular events. So just something to note. Now, in the 2026 guidelines, you'll find this algorithm, and I think it's important to recognize that they also comment on ESA hyperresponsiveness and kind of frame it in how HIF-PHIs should be used in that context. And actually the recommendation in the new guidelines is that one might consider a 3 to 4 month trial of HIF-PHIs for persistent or unexplained ESA hyperresponsiveness. So just to highlight that point. Okay, so that kind of brings me nicely to my next slide to talk a little bit more about hypoxia-inducible factor pathway. So then we can take a look at how some of the HIF-PHIs actually work. So hypoxia-inducible factor regulates multiple genes as a response to hypoxia via transcriptional effects. It regulates RNA expression and enhances the function of other transcription regulators. So if you look to the figure on the right there, what happens is, under normal oxygen and iron conditions, you have these enzymes called the PHD enzymes, or the prolyl hydroxylase enzymes. And these hydroxylate the HIF-alpha subunit, which essentially targets it for destruction. But under hypoxia or iron deficiency states, or even with use of the HIF-PHIs, this hydroxylation is suppressed. And as a result, the HIF-alpha unit stabilized, it accumulates, and then gets translocated to the nucleus, where it joins HIF-beta to form the HIF-alpha-beta complex. This complex then binds to hypoxia response elements in the genome, leads to a cascade of transcriptional effects with upregulation, as you can see here, DMT1, which is important for iron absorption in the gut, suppression of hepcidin, upregulation of transferrin receptor expression, EPO and EPO receptor expression, and the net effect is an increase in erythropoiesis. But what's important to note is that HIF, when stabilized, doesn't just stimulate erythropoiesis. It can also upregulate other genes and pathways, such as VEGF and GLUT or GLUT, as shown here. And so the point to be made is that stabilization of HIF by PHIs might therefore actually lead to off-target effects. So, for example, abnormal angiogenesis. And this highlights the need, for careful evaluation of their safety. And you'll see then why certain conditions there is caution exercised with regards to HIF-PHIs. So there are 3 enzymes responsible for HIF degradation, one of which I alluded to already, but PHD1, PHD2, and PHD3. They're part of a family of iron and 2 oxoglutarate-dependent oxygenases, and they require oxygen as a substrate, and so act as oxygen-sensitive regulators of HIF activation. So HIF and PHIs work by directly inhibiting these enzymes and therefore prevent hydroxylation of the HIF-alpha and subsequent cascade of downstream effects, which I just showed on the previous slide. But the point to be made is that there are kind of different isoforms or of these enzymes, and different HIF-PHIs may selectively inhibit the different enzymes. So that may potentially account for why you see different different variation in the effectiveness between the different HIF-PHIs, but also different side effects across the different HIF-PHIs as well. So, for example, roxadustat is implicated in inhibiting PHD2, and PHD2 is often found in endocrine tissue. And so, for example, when you start roxadustat, it's advised that patients have thyroid function tests measured because of the concern for central hypothyroidism. And so that may be some of the off-target effects that we see with that particular inhibition of that enzyme. All right, so I'm not going to go into all the HIF-PHI versus placebo trials. You can see there are a lot of them. The bottom line is that when HIF-PHIs were compared to placebo, we learned that their physiological mechanisms translated into a measurable improvement in hemoglobin among patients with CKD. Similarly, there were a number of non-inferiority design trials that compared HIF-PHIs such as roxadustat, daprodustat, vadadustat, even inaridustat, molidustat, but they compared them with ESAs. Bottom line, when we looked at this, was that in non-inferiority design studies, the HIF-PHIs were as effective as ESAs in increasing hemoglobin. But although they were as effective, there were obviously concerns with their safety profile. So I think let's therefore look a little bit more closely at the vadadustat trials. So here we have the PROTECT, which looked at non-dialysis CKD with ESA-treated and ESA-naive patients, whereas INNOVATE looked at both incident and prevalent dialysis patients. Patients were randomized to either ESA or vadadustat. Key inclusion and exclusion criteria just shown here, as you can see. And in PROTECT, vadadustat failed to meet non-inferiority for cardiovascular safety with a hazard ratio of 1.17. The upper bound, as you can see there, of the confidence interval of 1.36, but the pre-specified non-inferiority margin was 1.25. In contrast, the INNOVATE trial, which looked at the dialysis patients, vadadustat did meet the non-inferiority margin for cardiovascular outcomes. Both trials met non-inferiority criterion for the primary efficacy endpoint of mean change in hemoglobin from baseline, meaning that essentially vadadustat was just as effective as ESAs in raising the hemoglobin. Then, if we take a look at daprodustat trials, so we have the ASCEND-ND, which included patients who were either approaching dialysis or recently started. We also have the ASCEND-D trial, which included stable dialysis patients with anemia. Both trials, patients were randomized to daprodustat or ESA, and the key inclusion-exclusion criteria here were the same. Primary efficacy endpoint was a mean change in hemoglobin from baseline, and the primary safety endpoint was major adverse cardiovascular events. And so for efficacy, both trials met the non-inferiority criteria. For safety, both trials also met the non-inferiority margin for major adverse cardiovascular events, with the upper bound of the confidence interval below 1.25. And so you can see with a hazard ratio of 1.03 in ASCEND-ND and a hazard ratio of 0.93 in ASCEND-D, meaning essentially there was no signal of excess cardiovascular events or cardiovascular risk compared to ESA use. Okay, so with that said, so where do we stand now in the 2026 guidelines with the HIF-PHIs? Well, certainly the thing to note is they make an explicit appearance in these guidelines. It is recommended we do not use ESAs and HIF-PHIs in combination. Hemoglobin thresholds for initiation and maintenance of HIF-PHIs are unknown, and essentially a lot of it's extrapolated from the ESA literature. The recommendation, though, is that the hemoglobin levels be monitored for 2 to 4 weeks after initiation or dose adjustments, and every 4 weeks during maintenance phase, and that they are discontinued after 3 to 4 months if the desired response has not been achieved. And finally, they do not recommend their use in active malignancy, recent cardiovascular events, thromboembolic events, or vascular thrombosis. Equally, in the 2026 guidelines, in patients, they identify patients with anemia and CKD who may be at risk for adverse events with HIF-PHIs. And they define this into kind of 3 categories: theoretical or experimental risk. And you can see here, for example, proliferative retinal disease. So when you consider the off-target effects, maybe on VEGF, abnormal angiogenesis, that makes sense. Concern for risk with a history of cardiovascular events, thromboembolic events, etc. Hypothyroidism, as I previously alluded to, with roxadustat. And there's insufficient data to comment on their use in post-transplant anemia or in the pediatric setting. So again, this is just a summary slide comparing ESAs and HIF-PHIs in KDIGO 2012 versus 2026 guidelines. Just important to note the suspension triggers in the 2026 guidelines for ESA use, so to suspend during hospitalization for acute stroke, vascular access thrombosis or thromboembolic events, and that the preference is ESA over HIF-PHIs as first line. And then finally, the HIF-PHIs are new. They make an appearance in the 2026 guidelines explicitly. But again, a lot of the data in terms of the HB thresholds is kind of extrapolation from the ESA literature. So in summary, iron deficiency should be corrected across the spectrum of kidney disease, even in the absence of overt anemia, which I've showed. ESA use should be guided by evidence from placebo-controlled trials. In particular, the TREAT trial has guided us in this regard. ASA hyperresponsiveness as a concept is important to recognize and work up, and increasingly we're recognizing its association with adverse clinical outcomes. And although HIV/PHIs show promise, their approval and use has been limited by safety concerns. So in terms of the US specifically, only 2 have been FDA approved, vadadustat, daprodustat in dialysis patients only. Vadadustat was approved in December 2024, despite initial rejection 2 years prior. And then daprodustat was initially approved in 2023, but then withdrawn in 2024, which as far as I'm aware was a sponsor-related decision and not related to safety concerns. And then, of course, specific guidelines on hemoglobin thresholds or maintenance with HIV/PHIs is actually extrapolated for ESA literature, and that's just something to be mindful of. And then finally, guidelines are guidelines, and as such should be thoughtfully integrated into patient-physician discussions. And I think the thing to take away from the newer guidelines is the emphasis on shared decision-making and individualization according to patient preferences. So something to think about. Okay, so thank you very much. People have questions, please forward them.